Sawadika, we are back with you live for these interview sessions outside the conference rooms as part of the 19th Bangkok International Symposium on HIV medicine. My name is Paton Rockstroh. Now, just wrapped up, just now, we had a session on ART in real life practice. Now, we've been talking a lot about antiretroviral therapy, and now we're going to focus on how it's implemented in everyday life for the patients, etc. And sitting right next to me, who took part in that session, we have Professor David Cooper. He's the director of the Kirby Institute for Infection and Immunity in Social Subject. That's not right. In society. That would be more correct. That's right. And you're from New South Wales in Australia, University of New South Wales. All right. Thank you very much for coming back.
Thank you.
For a second time today. Now we're going to go back to a 101 class here and go back to the basics. Do tell us, what is ART?
So ART, as we know it, right now, is a combination of usually 3 drugs which are antiviral, specifically against the HIV virus. And these drugs are targeted towards some of the enzymes and proteins of the virus that require it to grow, that enable the virus to grow. Mm-hmm. If you use only 1 or 2 drugs, it's not enough to control the virus, and the reason for that is the virus becomes resistant to the drugs. But if you use 3 drugs together in combination, then the virus cannot escape from those 3 drugs.
So monotherapy, that's not so effective?
Monotherapy is in general not effective, with a few very rare exceptions.
Right, so there are several types of ARV, that's what we call them, right? Antiretroviral drugs, ARV.
Correct.
How many types are there out there?
Well, there's almost 30 different drugs that are approved, at least in first world countries, and many of those, of course, are available in low and middle income countries. These drugs are in a number of classes. The most usual class are what are called NRTIs, or nucleosides. And that's, for example, tenofovir and AZT. The next class that's in common use are what are called non-nucleosides, and the most common example there is efavirenz or nevirapine. Mm-hmm. And the third major class are protease inhibitors, and for example, drugs like atazanavir and darunavir or lopinavir are commonly used. And the fourth really important class of recent development are integrase inhibitors. Mm-hmm. And for example, raltegravir, elvitegravir and dolutegravir are examples of that class.
Right.
And we select 3 drugs in combination. It's usually quite simple. We have what's called an anchor drug, which is the main component of the regimen, and that can be a protease inhibitor or a non-nuc or an integrase inhibitor, and it's usually combined with what's called a nucleoside backbone. Mm-hmm. And that nucleoside backbone is usually tenofovir and another drug called 3TC. Right.
And how effective is this method of treatment using ART?
So the main requirement for using ART is to take the treatment every day. And if you don't take it every day, mm-hmm. and in fact if you miss, the general issue is, the general notion is not to miss more than 1 in 20 doses. If you miss more than 1 in 20 doses, you're at high risk of developing failure on that regimen and resistance.
Excuse me, may I interrupt you? 20 doses, this is within 20 days? Or?
Well, so if it's a once-a-day regimen, then it would be 1 dose every 20 days. That's the usual standard, mm-hmm, right? Mm-hmm. That's what you counsel patients that they shouldn't miss more than one dose in 20 days, right? But you stress to patients that they have to take the drug every day. But people are human, you know,
yes,
they forget and
misplace
it, or they're on vacation, they forget to pack their pills, or they're at work, or they're out for dinner, and you know, so everyone's human. So we give them a little bit of leeway. Now, most people are able to adhere to that, particularly if it's done in what's called a fixed dose combination. Right? So a fixed dose combination is where you put the 3 medications in the one pill, right? And so the person only has to swallow one pill once a day. It's very easy, right? And that certainly helps what we call adherence, right, or sticking to the regimen. Right?
Which is extremely important, as you mentioned there.
Extremely important.
What are some side effects?
So it's quite remarkable. Initially, when we had the older, more toxic and clumsy type of regimens where people had to take maybe up to 20, 25 pills a day, many of them were associated with quite a lot of side effects, right? Gastrointestinal side effects, anemia, neuropathies, various body composition alterations called lipodystrophy, which made people look ghastly. But now with these new regimens, they're remarkably safe.
So we've come a long way, haven't we?
We've come a very long way. And they're very safe, and the vast majority of patients have almost no side effects. Now that is pretty amazing, because you can't be better than someone not taking anything, right? Right? You know, so
yes.
Anybody taking a medication does have some side effects. You know, that's just one of the issues. But this overall, the rate of side effects is really extraordinarily low with some of these modern combinations.
So there is no reason to fear treatment, to fear medication, as it's so easy and the side effects are minimal.
Correct.
Right. So therefore, we encourage you all to get tested, and if you happen to be HIV positive, to start treatment. And we also hear a lot about same-day ART. Tell us what that is.
One of the issues that we've found, particularly in low and middle income countries, where healthcare systems tend to be quite clunky and tend to be stretched, and for no good fault of the people who staff those clinics, right? It just doesn't provide a very smooth transition for people. So that if someone gets tested at one facility, referred to another facility, goes somewhere else to have a blood test, then goes somewhere else to be counselled, it's a whole rigmarole, right?
And it's very tiring for the patient.
It's very tiring for the patient, and it turns out that quite a number of patients just get lost in the system and they don't come back to the clinic. Right. So one of the and we've found that this has been quite a problem. So anything that makes the healthcare system cumbersome becomes a barrier and makes the person not want to come back. Now, in low and middle income countries, keeping a job is critical for some people. They're on the borderline for themselves and their family. If they have to take a day off work,
several days,
they don't earn anything, and they have to pay for transport to the clinic, right? It is a barrier, and that promotes what we call loss to follow-up and non-adherence, right? So what we're trying to do is to make our healthcare systems much more user-friendly. And so what we do is that we get the people tested, and as soon as they're tested positive, they come to the healthcare facility when we do everything on the same day, and here you are, here's your bottle of pills, you start right away.
Great.
Right? And that reduces the barriers. You then tell them to come back in a month to see how they're going, and then generally they come back every 3 months. Now, there have been some really unique systems that have been tested around the world. So, for example, in South Africa, where 50 people in a community may have HIV and the stigma and discrimination is minimal, they elect to have one person on rotation, right, go to the clinic and pick up everyone's medication.
Lovely.
Right?
How convenient.
And if they're well, why do they, and they're taking their medication every day, you know they're undetectable, why do they need to come back to the clinic?
Yeah.
Right. Earlier this week I was in Myanmar, right? So in one particular clinic they've got 8,000 people on ART. That's a production.
Wow.
So they have a green line, red line system, like you go through customs when you land at an airport. So it says if you've got no problems at all and you're just here to pick up your meds, just go into the green
lane. Okay.
Yeah, go through the green lane.
If you need further
if you're
advice,
not well or there's some
it's
problem
not working,
or not working for you,
take the red line, we'll try and see you as soon as possible.
Wow, that's a super idea. That's really facilitating them.
Yeah, so I think everyone's adapting to making it easy for people.
Yeah.
This is a lifelong treatment.
Exactly.
Right? Yeah.
And that is ART put into real life practice and making it easier for them. Not that they're disheartened, oh, let's forget it, let life take its course, whatever happens to me, forget it, I have no support. That's not good. That's not good. Thank you so very much for the basics there. Now we're going to continue to discuss this further and how ART is put into practice, but we're going to bring up another guest who was also there as a panelist for some of the sessions here. Kun Chureeratana Bowonwatanuwong from Internal Medicine Department of Chonburi Hospital. Let's welcome the doctor right here. Sawadee ka. Thank you very much, Dr. Chureeratana, for joining us. Once again, she's at Chonburi Hospital, the Internal Medicine Department. And I'm going to leave it up to you now, Professor David Cooper, to ask the questions.
Okay, thank you for coming. So one of the things you raised at the session we were discussing various patients with various clinical problems, right? And one of the very early patients we discussed was a very young man, a 21-year-old gay man, right, who became HIV infected, but he was using drugs, right? And our colleague questioned about his drug use because it was said that he was using heroin, right? Which is very unusual in a young gay man in Thailand. They usually use other recreational type drugs. So can you tell us about your experience of, young MSMs, young gay men and drug use and how it affects them and affecting taking ART?
Yeah. I have to identify myself. I'm from Chonburi Hospital. It's a midway between Bangkok and Pattaya.
Yeah.
So I was.
So either way, you see a lot of gay men.
Between Patpong and Pattaya. So I am maybe
the two parts.
It's a strategic location.
When I start my career in the HIV infection, I didn't have any experience about the MSM.
Right.
But because of nowadays, the MSM is one of the key population, and we have to learn about what happened with them. Apart from the active sexual life, they have the recreation drug. And this morning, when the case presentation that they use the heroin, which is a really unfamiliar for nowadays, because the heroin usually be the drug addict in the past maybe decade. and especially in the southern part of Thailand, you use heroin. But nowadays, usually they use the methamphetamine, the ecstasy, and this can create the adherence is very poor. They will forget everything and did not take the medicine or antiretrovirals that lead them to the failure. And the point is that this group, they have a very active sexual life and swing among that group.
Oh
so
dear.
it will transmit the failure, the strain to the other.
So what's your strategy for young MSMs who are using a lot of recreational drugs, and particularly methamphetamine, which is very destructive, right?
Yeah, I have to accept that. In fact, I'm like a ordinary clinician. I didn't have any special experience about the MSM or the methamphetamine, but luckily in Pattaya, there is a very active group. We call by themselves with the group of the MSM and transgender, and they have the direct experience with this group of patients, so they can counsel among them. It is easier, but I learned from them too.
So how effective is ART to these patients when you've got this factor now, recreational drugs? Does that stop the ART from working as effectively as it's supposed to?
Yeah, they maybe have the effect. The first thing that I mentioned in the conference, that maybe have some drug interaction between the antiretrovirus and the IVDU or the methamphetamine. The second thing that they will interfere with the normal life, with the adherence, that will create the resistance, failure and resistance of the treatment.
Well, that's not good, because then you're going to create a ripple effect, and if they're sexually active with many partners, as you said, they swing a lot, then that's going to spread it even more. And this is alarming. So how do we address this?
Well, so I think it's really critical that we try to adopt PrEP quite widespread in MSM in Asia, right? So there is a huge MSM epidemic going on in large Asian cities, whether it be Jakarta, whether it be Bangkok, whether it's Ho Chi Minh, whether it's Guangzhou. There, all of these big Asian cities have huge MSM epidemics, and we know how effective PrEP is in prevention. Right? Of getting HIV. It's if you take 4 doses of PrEP a week at least, then you're protected from getting HIV. So we've got to convert the culture of young MSM in our large Asian cities into using effective PrEP.
Now, I think the term of the PrEP, pre-exposure prophylaxis, is like a new term, just currently about 4 or 5, not more than 5 years. But it's very active in terms of the study. And we have the data that Dr. David have already mentioned.
I know from speaking to other guests who have joined us for the interview that PrEP is extremely effective, but it's not for everyone, and not that you come across PrEP and then you throw away the condom, etc. No, you still have to practice safe sex, and you can't rely 100% on PrEP.
That's correct.
Yeah, it's the additional weapon, because we learned that from the last 2 decades that with the condom, with the heavily counseling, the prevalence of the MSM is still really high. So we have to look for a new weapon.
Now, our next guest is from Europe. So before I let you go, I really want to better understand the context here in Asia. As you mentioned, what some of the big cities here, Jakarta, Ho Chi Minh, Myanmar, and here in Thailand, in Bangkok, or where you are strategically located. Are they aware that there is this what another doctor termed modern day medical miracle, ART, PrEP? Are they aware that there is this in existence that will help them? Because that's important. We've come this far in terms of research, we have this for you, but are they coming to seek help? Are they getting tested?
Yes, there's very widespread publicity of these modalities in social media. I mean, young people, not us, use a lot of social media, right? And so young MSM use, young gay men in Asia are big users of Grindr, right? You know, to find friends and sexual partners. So we're using the NGOs who work with gay men or key affected populations, as we say, use Grindr very effectively to tell,
get the word out.
To tell them about them, get the word out, right? And let them know where they can go to get tested and where they can go to hear about PrEP. So I think we're using, you know, the revolution in social media is really being to our advantage for these young populations.
All right.
Only
please.
one point, as a provider, I think that we now recognize that how important the prevention is. So for me, I use especially 2E. The
2E.
first E is how to educate them to know that how important, how effective of the PrEP. And the second one is to ease them can access to the prevention measure easily. So with these 2E, maybe improve the prevention of the prevalence among the gay men or the MSM.
There you go. So the 2 E's, to educate them and to make it easy to access it. Thank you so very much, Dr. Chureeratana Bowonwatanuwong, Internal Medicine Department at Chonburi Hospital, halfway between Pattaya and
Patpong.
And Patpong. Patpong is red light district here in Bangkok. Thank you very much indeed. Thank you. You're still going to be with us, Professor David. Now we heard a bit of the Thai context, the Asian context. Let's now bring in another guest. So he's the head of the HIV Outpatient Clinic, University of Bonn in Germany, Professor Juergen Rockstroh. I hope I pronounced that correct.
Oh, that sounded wonderful.
Thank you. Oh, but you have a very American accent.
Couldn't pronounce it any better.
Oh, thank you very much for joining us. So we continue to talk about ART in real life practice. I'm going to hand things over to you now.
So this is a change, right?
This is a challenge.
A change and a challenge.
Exactly.
So, Professor Rockstroh, one of your very special interests in which you've made enormous contributions in HIV is in the area of hepatitis co-infection. Right? So there are a lot of people, key affected populations in Asia that are at risk and indeed have hepatitis C. So young gay men, injectors, some sex workers and so on who may use drugs or have been infected by their partners. So there's a big move to get these new dramatic Hep C treatments out in Asia. Perhaps you could just tell us a little bit about these treatments and what you think should be happening and what is happening in Asia to get these very effective treatments rolled out.
Yeah, so I think the important thing to know is that with the availability of new drugs, which are called direct-acting antivirals, so forget the interferon, you can even forget the ribavirin, with new drugs which target the replication of hepatitis C, you can successfully eliminate hepatitis C out of the body. So in contrast to HIV, the goal of therapy is cure. So that's obviously the big difference. And with these new drug combinations, be it 2 or 3, you can achieve an over 95% of people a cure. Now obviously the before mentioned outbreak of acute hepatitis C among the MSM HIV positive population has really struck every country now, almost globally. It started off in European countries and in the United States and Australia, particularly big cities where there are large communities of MSM. But now has also been an outbreak in Taiwan, in Hong Kong, and in Bangkok. So really reaching the Asian region. And the big issue here is that during seroconversion, very much like in HIV, patients are highly viremic and very contagious, and actually that's probably one of the big sources of transmission. It has been shown that they're shedding of hepatitis C, also interrectal fluids, and so there seems to be unprotected anal intercourse seems to be one driving force, and then also risky sex practices with a high risk of blood-blood contacts further contribute. And unfortunately, there has been no registration for treatment during acute hepatitis C, so we're really still lacking sort of in the label an indication to treat during acute hepatitis C, which would be absolutely instrumental in preventing further spread of disease. And obviously these drugs, which are highly successful, are great, are super tolerated, can be given over short cycles between 8 and 12 weeks, have an issue of high cost. And I think one of the most fascinating stories, though, in the last couple of years, 3-4 years, since the advent of these new drugs, has been really how fast that has sort of been taken up, and generics have been very instrumental, which are mostly produced in India, and there has been access also in the Asian region from generics in India, and that has led to first treatment experience. And I think the first reassuring message is that the response rates are just as high as with other drugs from the branded manufacturers. So that's very reassuring, and hopefully we'll see an even bigger uptake and more utilization. There are ambitious programs in the MSM population, be it Australia, your own country, or in the Netherlands or in Switzerland, where they're aiming at treating every HIV-infected patient with hepatitis C, because you know these patients. They come for regular intervals for CD4 count check, and then you can sort of, determine whether they have hepatitis C. If they do, they all get treated, and then to see, can you then see a decrease in new infections? And there is first work suggesting that actually that is happening. So that might be the good news, that we can actually control this epidemic by delivering care immediately in patients who get infected.
So what if that it's very encouraging, that strategy to eliminate hepatitis C in key affected populations, for example, injectors or prisoners, as we're doing in Australia, or gay men. If it doesn't work, what are the other prevention strategies that we should be looking at?
Yeah, well, I think the first thing is that what we shouldn't forget is that although we're talking a lot about MSM and transmission of hepatitis C, the biggest source of infection still is intravenous drug use. And obviously we know very well that opioid substitution programs, needle exchange programs are extremely successful. And unfortunately, it's really criminalization of IV drug use or IV drug users, political issues which sort of make it impossible to implement these programs in many countries show that obviously if there is no safety measure, then that is further going to spread. So you can see that in many African countries, particularly in Eastern Europe and Russia, there is absolutely no attempt for establishing programs which we know so well to prevent HIV infection, obviously also to prevent hepatitis C infection. So that is, I think, one of the hugest issue is that passing out of drugs alone is not going to be enough. What we really need to do is make sure that all these programs which have been proven to be safe and effective are implemented everywhere, and that criminalization of IV drug users stops.
And tell me about condoms in gay men. What's the data in terms of that preventing?
Yeah.
So if you've got someone, with HIV on treatment and his partner's on ongoing PrEP, for example, and he's having multiple sexual partners and maybe chosen to not use condoms, should we be counselling to use condoms to prevent Hep C, for example?
So that is one of the most controversially and hotly debated topics among gay men and community members, and for obvious reasons, because a lot of people feel that being undetectable, not being at risk of transmitting, people being on PrEP sort of has really led to a huge change in behavior. And in the PrEP studies, the authors say, well, we don't really see a notable rise in STDs in that period of time the study was conducted. I would say, though, that as a little controversial issue, that to enter the trial, you had to have a history of several acquired sexually transmitted diseases. So the question is, if you already have one STD per month, how is that necessarily going to increase further? So is that really the right group to say? Because you already have such a high number to start with, so that doesn't necessarily change. And I think that if you look at the PrEP trials, and remember that because of the high efficacy, they were terminated early, so you also do not have a long follow-up. But if you extend the follow-up of these individuals, you would see that there are cases of hepatitis C. So I would absolutely say that in the context of promiscuous sexual intercourse, if you don't want to get hepatitis C, using a condom still makes a lot of sense, and I think patients should be counseled appropriately.
Right. Okay. So one last sort of prosaic question, if you like. So needle stick injuries in healthcare workers have always been a huge issue for us, right? And it's one thing to get HIV as a healthcare worker, which undoubtedly happens. Much less now because so many people are on treatment, but it does happen, and that would commit the healthcare worker to treatment for life, right?
Yeah.
Now, Hep C, on the other hand, right, awful situation if you got it pre these DAAs, right? Terrible. What's the approach, for example, in your hospital now to needle stick injuries in healthcare workers who might be at risk of Hep C?
Yeah, so the transmission risk for Hep C is 0.3%. So it is not higher than with HIV. I think that's important. So the likelihood is still very small. There is, in contrast to HIV and HPV, we have no data on pre-exposure prophylaxis or post-exposure prophylaxis. There's been one post-exposure prophylaxis with interferon in the old days, but the seroconversion rate was the same as people who didn't receive prophylaxis. So there is no clear signal whether that works.
Probably because they didn't take the interferon.
Yeah, exactly. And interferon is obviously not a drug, and so you think 0.3%.
Yeah.
And remember that when interferon was our sole drug of choice, everyone who received it after seroconverting, those few who did, they all went on to clear infection. So treatment during acute hepatitis C with interferon was almost 100% clearance rate, at least in the original New England Journal paper. And so we felt like you wait, if someone really seroconverts, you treat immediately, and then you sort of get through that. Now, obviously, with DAs, things become much easier because you have much better tolerated drugs. And what we do in Germany is then we write to the corresponding person who has to pay the bill at the end of the day, and then say we're going to treat with DAs, and they say okay, and that's what we do. So in those very few cases which have occurred, then we would treat for probably a shorter duration of 6 weeks, and then that leads to 100% cure. So I think the good news is that if you're a healthcare worker and you get really, in the unlikely event of getting a needle stick injury where you really seroconvert, you have a very high probability of being treated successfully subsequently.
Right. Thank you very much. Unfortunately, that's all the time we have for this segment. Thank you, Professor, for coming in to chat to us. Professor Juergen Rockstroh, Head of HIV Outpatient Clinic at the University of Bonn in Germany. Dankeschön. Nicht sprechen Deutsch. And we also thank you, Professor David Cooper. I'm going to get this correct this time. The Director of the Kirby Institute for Infection and Immunity in Society at the University of New South Wales in Australia. Thank both gentlemen so very much indeed. Alrighty, we are now going to continue here with two more guests, and we're going to bring our two guests up here, starting with Dr. Opass Putcharoen. He's at the Division of Infectious Disease, the Department of Medicine at Chulalongkorn University here in Thailand. Sawadee ka, Dr. Opass. You're going to take the role of interviewer, and we're now going to bring in the interviewee, who I'm sure has a lot to share with us as we go into the topic of new drugs as well as new treatment strategies.
Yes.
Exciting indeed. So let's bring on, we have Mr. Nicholas Paton from the National University of Singapore. Sawadee ka. Over to the topic of new drugs and new treatment strategies. Dr. Opass, you'll be posing the questions, I believe.
Okay. So please tell me about the why do we need new drugs for TB treatment? Because we have known the disease for many years. Why still need more drugs in the pipeline? What's the problem with current drugs that we have?
Indeed, so you're right. We've known about TB for many years, had 60 years of experience in developing treatments for TB, and we've had a combination treatment for the last 40 years, which has worked extremely well for TB. But over time, as with many infections, the organism has developed resistance, largely driven by people adhering poorly to the treatment. So that's a way to breed resistance, and that's started to spread in the community across the world. So now we have a problem with drug-resistant TB, multi-drug-resistant TB, extensively drug-resistant TB, and totally drug-resistant TB in various levels in different countries. But so the reason we need drugs is because the standard treatments, which still work well for the majority of people, don't work in some of these people with drug-resistant TB, so we need new options for them.
So could you explain more about what is MDR-TB and what is XDR-TB?
So MDR-TB is when you have resistance to the two main drugs of the first-line regimen. So there were 4 drugs in the first line: rifampicin, isoniazid, pyrazinamide, ethambutol. MDR-TB, multi-drug-resistant TB, is when you have resistance to rifampicin and isoniazid. XDR-TB is when you have resistance to the 2 most important second-line drugs, one of which is an injectable drug, so amikacin or kanamycin, plus a quinolone. Those are the sort of next rank of what you turn to in second line. So if somebody's resistant to those, then you have an even bigger problem. That's XDR-TB.
So this is very challenging because we now facing the problem with MDR and XDR-TB. Are we losing the game?
I'm not that pessimistic. I think actually in the last few years particularly, there have been a number of good options come along. So particularly an almost fortuitous discovery a few years ago of a combination using some old drugs, including a drug previously used for leprosy called clofazimine, and also increasing the dose of some of the quinolones. That combination with a few other drugs seems to work extremely well. As I say, it was almost a fortuitous discovery, and at the same time as having increasing the cure rates quite dramatically, it also cut down the duration of the treatment from a terrible 18 to 24 months, really unpleasant for people, down to 9 months. And actually last year the WHO adopted that as really the cornerstone of their therapy for multi-drug resistant TB. It still doesn't work for everyone because they may have resistance to one or more of the drugs in that regimen, and so we still have to go back to choosing from a shopping list of alternatives. But I think that's a major advance just in the last year. Cutting from 24 months down to 9 months with an increased cure rate. Yeah. Plus, we have some other new drugs which have come through the more conventional route of drug discovery. So bedaquiline, delaminid, there's another one in the pipeline called pretomanid, which also appear to work quite well. So I think in a way it's like HIV. There was a period of pessimism where it looked as though we were running out of options. But once you get a few good options coming together that then you can combine, that kind of turns things around a bit. The challenge is to get that treatment to people and stop them transmitting, stop them getting resistance to those drugs as well, and then making the problem go worse. But at the moment it's quite optimistic.
Great, that's very good that things are looking very good. What are some of these side effects, and with these new drugs, are those side effects reduced even further?
Well, unfortunately, because we're scratching around, all of the drugs have side effects. Yes. So particularly for multi-drug resistance, the injectable drugs mean you have to have a daily injection each day. It has problems with toxicity to the kidneys and so on. A lot of drugs have problems with rashes. The clofazimine, which is now pretty much the mainstay of this new 9-month regimen, has a problem with skin pigmentation, which a lot of people don't like. Culturally, sometimes that's a difficult thing for patients to accept. So those kind of things make it quite difficult. The quinolones are generally well tolerated. Overall, if you look at the overall percentage of people who have to stop treatment due to side effects, it's not so great. So they can be managed, maybe 10-15% run into problems with side effects that really means you have to stop the treatment. But all of the drugs have, unfortunately, some toxicity that needs to be managed for the second line drugs.
Okay, we have time for one final question, Dr. Opass.
So can you tell me more about immunotherapy for TB, what it is?
Yeah, this is a really exciting area which, surprisingly has been neglected over the last 40 years. I guess just people thought we were doing fine with the current standard treatment. But it makes absolute sense to try and improve the immune response to TB, because in the past, before we had drugs, actually a lot of people cured themselves of TB. That was their immune system doing the job. And we've kind of focused on drugs that kill bacteria and forgotten about, well, actually, maybe we can get the immune system to help do the job too. So, and we're learning from the oncologists who in the last decade have really discovered this area. Instead of drugs that target tumors directly, they're actually using the immune system to fight the cancer. Again, we can learn from the oncologists and use that approach to try and boost up the immune system to try and clear the last vestiges of TB in the body, instead of having to treat for such a long time and get the drugs to do it.
Is the result of the trial is promising?
So this is embryonic. I wish I could say yes. So there's an explosion of activity at the moment. Well, explosion by TB standards. So there's an increase in activity in host-directed therapy for TB. So there's some trials starting in South Africa on a range of options. We have just completed one, a very exciting trial, which I'll talk about later, on blocking one of the key cytokines in the TB response that might actually help to boost up the clearance of the bacteria. So it's early days, but the important thing is the trials are starting and they're being done properly, and then we have to wait some time before those results come through. But hopeful.
Sounds promising there.
Yes.
Thank you very much, Professor Nicholas, for being with us here. And you're at the National University of Singapore, not too far from Bangkok
Welcome.
here. Thank you. Khop kun ka. All right, we're going to continue to focus on TB, tuberculosis, and getting the global perspective now and ending TB for good. He joined us yesterday, and we'd like to ask him back with us again. Professor Frank Cobelens. He's at the Academic Medical Center in Amsterdam Institute of Global Health and Development. Hello again,
Hello.
Professor. Sawadee ka. Continuing with tuberculosis and finding an end to it. Over to you, Dr. Opass. He's going to be throwing you the questions.
Can you tell us briefly about the global burden of tuberculosis right now? What is the major obstacle of in treating patients with TB globally at the global perspective?
I think that over the past decades, tuberculosis diagnosis and treatment has been there and has been more or less standardized for the past 30, 40 years. And I think it has been hugely successful in avoiding deaths, in curing patients. But what you see is that at least at the global level, there isn't really a decrease in incidence of tuberculosis. So the estimates by the WHO are that the decline is very, very slim. And of course, some countries have made great strides, such as China, Thailand, actually done much to improve the tuberculosis situation. But for the large majority of very poor countries where TB is a major problem, this has not yet been achieved.
Mm-hmm. So what should we do? Because the end of TB is very, I think it's very difficult and very challenging.
Well, I think WHO has been right to be very ambitious here and to set a target of actually eliminating tuberculosis as a major public health problem by the year 2035. That is going to be a huge task, but I think it is not undoable, and I think you should also, as a global community, you should believe in certain things and just try. And I think the important take-home message there is that we can do an awful lot with what we already have. You've just been discussing the currently existing drugs. Drugs coming out of the pipeline, but in the end, in order to really get rid of tuberculosis, we need more. We need to look in particular, I think, at prevention. We need an effective vaccine, And I think in the meantime, we need a way to reduce the large reservoir, if you will, of patients who carry tuberculous bacilli but are not ill, but in the end can become ill by preventive treatment. And there is still a lot of work to be done.
Right. Now, I'm so sorry that I have to cut this short. You are wanted in the main conference room because it is now 1 p.m. here in Bangkok, in Thailand, and we're going to start the symposium, that session on TB, Find Me Faster and Treat Me Better. So we're going to head inside the conference room and hear your presentations there and find out what you have to say. But we have to thank you, Professor Frank Cobelens, for joining us once again over into the meeting room now. You're wanted there, and we're going to follow you right in there as well. Thank you very much.
Thank you very much.
Thank you. And I'd like to thank you as well, Professor Dr. Opass, for joining us here. Thank you. Thank you. Let's now all move into the main conference room, and do join us again in a short while from now. That would be at 2:30 for more, and we'll be discussing hepatitis B virus, Hep C as well. We heard a little bit about that during this session, and also access to medicines and ending Hep B, Hep C. That's at 2:30. Thank you very much indeed for joining us. See you later. So I can have